Our next speaker, is Dr. Sharma. She'll be talking about fighting fungal keratitis.
At the outset, I would like to thank the organizing committee for making me a part of this presentation, and I would be talking to you about fungal infections. There are no financial interests or disclosures, and it is very important to know when you are treating a case of microbial keratitis, for that matter, where geographically you are located. So just to give an example, if you're in North and West India, Aspergillus is the one which is most commonest, but if you're in South and East India, it is Fusarium, which is most commonest. The clinical features of fungal keratitis include dry, thick, raised texture, feathery margins, satellite lesions, endothelial plaques, and fixed hypopyon. And specific signs may be there with specific fungi. For instance, you may have brownish pigmentation, which resolves after treatment. Fusarium tends to have a severe course, and yeast has collar button configuration. The mainstay for a diagnosis of fungal keratitis is smears, and generally smears are sent for 10% KOH as well as gram stain, which turn out to be positive, and cultures are sent for Sebrot's dextrose agar media. In cases which are culture negative and are deep fungal keratitis, one can even do PCR and confocal microscopy, and if hyphae are present, one can start antifungal therapy. We've also evaluated the role of spectral domain anterior segment OCT in cases of fungal keratitis, which is especially useful for posterior abscesses, and it also gives insight into the activity of keratitis. 5% netamycin is the mainstay for a case of fungal keratitis, which is given hourly during the daytime and 2 hourly at bedtime, and one tapers it over 4 to 7 days interval. If there's worsening, then one can add 1% voriconazole, and therapy lasts for 3 to 4 weeks. This is a case of Fusarium keratitis, which healed on topical netamycin. The MUT1 trial did teach us that voriconazole should not be used as monotherapy in cases of filamentous keratitis. The currently available topical antifungal agents have limitations in the form of poor ocular penetration, bioavailability, and toxicity. Systemic antifungals, on the other hand, were used for large ulcers and for severe deep keratitis, and ketoconazole and voriconazole are the most commonly used systemic antifungal agents. This is a case which did not respond on topical netamycin alone, and systemic ketoconazole was added to cause resolution. The MUT2 trial compared oral voriconazole and oral placebo and showed that Fusarium keratitis cases may benefit from the addition of oral voriconazole to topical netamycin. We also compared oral voriconazole with oral ketoconazole and in a randomized control trial, and we found that there was no difference in the duration of resolution of infiltrates. But when we looked at the tear film and the serum concentration, the penetration of voriconazole was found to be significantly superior in the serum as well as in the tear film as compared to ketoconazole. There is a role of targeted drug delivery in the form of intracameral and intracorneal injections in select cases, and intracameral injections are indicated in cases which are not responsive to medical therapy with thick hypopyon, endothelial exudates, and deep anterior chamber exudates, and amphotericin B 5 to 10 micrograms and voriconazole 50 to 100 micrograms per 0.1 ml can be given. This is a large case of large hypopyon which resolved on intracameral amphotericin B. Intrastromal injections, on the other hand, are indicated in cases of deep mycotic keratitis, non-perforated corneal ulcers, not responsive to conventional topical and systemic antifungal therapy for 4 weeks. This was a case way back in 2005, which we were actually planning to do a therapeutic penetrating keratoplasty, but we gave a trial of intrastromal voriconazole, and this resolved on therapy. Subsequently, we published a case series on intrastromal voriconazole with resolution of the ulcers, and we also did a randomized control trial to compare the role of topical versus intrastromal voriconazole as an adjunct to netamycin in recalcitrant fungal keratitis. We did found a role of topical voriconazole, which acted as an adjunct in these cases, and this was significantly better as compared to intrastromal injections. Now, this is a video to show how intracameral and intrastromal injections are given. So AC parasynthesis is done first, followed by the washing of the exudates and injection of intracameral voriconazole. And subsequently, using a 30-gauge needle, one can give intrastromal injections in 5 to 6 hemimeridians in an area which is relatively clear and not thinned out. And we form a barrage over this lesion. 3 such injections can be repeated at an interval of 72 hours. And the reflex is very much like the reflex that you have in a phaco wound. So this is to sum up, which we came based on our own experience as well as the evidence which is present in literature, what we called as the topical, systemic, and the targeted therapy for cases of fungal keratitis or TST protocol. So if the ulcer is less than 5 millimeters in size with less than 50% stroma involvement, we start topical netamycin alone, and if there is no response, then we add topical voriconazole. However, if the ulcer size is more than 5 millimeters in size with more than 50% stromal involvement, we start topical netamycin and systemic antifungal agents. And if there is no response after 2 weeks, we add topical voriconazole. And if there is no response after 4 weeks, we give intracameral or intrastromal or both, depending upon where the exudates are. So this basically is a comprehensive protocol which covers all grades and severity of fungal keratitis. And this was on the basis of the more than 200 cases that we evaluated in a prospective study that was done at our center. If we look at the success rate of the TST protocol, the overall success rate is almost 80%. With the intrastromal group, it is 89%. In the medical management alone, it is 74.5%. We have also looked at the role of collagen cross-linking in case of fungal keratitis, and there are other groups as well who have looked at this and did not find any benefit of collagen cross-linking in fungal keratitis. Now, this is something that we are working at, and this is a cross-linked degradable drug-releasing patch, which we call as Netamatrix, which is now we've completed the animal studies, and this is intrastromally placed, and this is found to be useful in the animal models. And this is something that we've already worked at, and that is, if you look at netamycin 5%, it is a suspension. But in our lab at Ocular Pharmacy, we've linked it to a polymer, so it has become a solution, and we call this Netasol. And this has again been patented, and this is a water-soluble netamycin. And when we looked at single-dose kinetics as well as multi-dose kinetics, both the peak levels as well as the concentrations at all follow-up points was found to be superior as compared to 5% netamycin. So just to show one example, this was a case of post-LASIK fusarium keratitis, and we injected intrastromal Netasol because that's soluble, and this resolved on this intrastromal injections coupled with the topical drugs as well as systemic drugs. Sometimes you have to resort to more than one method by which you can treat fungal keratitis. This was a case of fungal keratitis for which a graft was done, and recurrence of infection occurred, and we gave intrastromal injections, and this resolved on therapy. So one weapon may not work in all the cases. And of course, when the medical therapy fails, then one can do glue, patch graft, or therapeutic keratoplasty in these cases. So to conclude, the current literature and studies have given several insights in the management of fungal keratitis. Comprehensive protocols are required to address all grades and severity of fungal keratitis, and more so for general ophthalmologists. Topical, systemic, and targeted therapy are the mainstay to treat these cases, and novel drugs, routes, and modifications will continue to evolve to improve outcomes. Thank you for your kind attention.